Good morning, and welcome to our webinar series on the Menopause Survival Course. My name is Brooke Hernandez, Physician Relations Liaison at the University of Chicago Medicine. The learning objectives for today's webinar will be to review the signs and symptoms of perimenopause and menopause, to understand available treatment options for menopause-related symptoms, to discuss lifestyle interventions for overall well-being in midlife and beyond. I would like to introduce our speaker for today. We have Dr. Monica Christmas. Dr. Christmas is the director of the Center of Women's Integrated Health and the director for the Menopause Program. We will have a Q&A session at the end of the presentation, so please utilize the Q&A feature located at the bottom of your screen. Without further ado, I will turn it over to you, Dr. Christmas.
Thank you, Brooke. I am so excited to be talking to you guys today about menopause, but more importantly, how we can all live a healthier, happier, better life as we move from midlife beyond. Hoping that I can dispel some myths, but also give everybody some really helpful tools in terms of managing this transition that I myself am going through as well. So I am going to share my screen and we'll jump right into the presentation. I want to leave time at the end to be able to answer your questions. So please, when you come up with them, you can either type them in the chat or wait till the end and give them to me personally. All right, so I hope everybody can see my slides. We're going to be talking about menopause, as you all know, which is why you signed up. So the big question is, what is menopause? I think everybody thinks about it as, well, my periods are stopped. But why does that happen? It happens because our ovaries stop making the reproductive hormones, in particular estrogen and progesterone. We are born with all of the eggs that we're ever going to have. And actually, by the time before we are even born, we start to lose them. But certainly once we start having menstrual cycles, we lose an egg every month, but we don't gain one back. So we hit a point where our ovarian reserve is just depleted. And that's when menopause happens. The natural menopause, we can define it after someone has not had a period for 1 full year. Now, Mother Nature has a sense of humor, because oftentimes I'll get patients that tell me, oh my goodness, I made it to like that 11th month. I was about to, either I did throw all my pads away or was about to, and boom, I got a period again. And sometimes I call it the last hurrah period. Sometimes it may come back and maybe be a little bit regular for the next couple months. Eventually it does go away. And that is a normal thing that can happen. The median age of menopause is about age 51 and a half, 52. But the range that 90% of people will fall into is between the ages of 45 and 55. And I guess a better way of saying that is by 55, 90% of people will have reached the full definition of menopause. Now, that does leave 10% of people that may go a little bit beyond 55, and it's still normal. But when we're over the age of 58, still having menstrual cycles, I think that's a point where, as a physician, we're looking to make sure there's not any other contributing factors to why that person may be having menstrual cycles. Symptoms related to hormonal fluctuations start up to 7 to 10 years before your periods actually stop. And that's what we define, or what's called perimenopause. And we'll talk a lot about symptoms of perimenopause and menopause in a minute. So natural menopause just happens because our ovaries, as I said, naturally stop functioning. They stop making our reproductive hormones. But menopause can also happen if your ovaries are removed too, or if the ovaries stop functioning due to a treatment. Most commonly, those treatments are chemotherapy or radiation, but there are even some other medications that can increase the risk or put people into menopause as well. I won't say increase the risk. Often people will say, when they're getting a hysterectomy in particular, is that going to put me into menopause? Having a hysterectomy, which just means that your uterus is removed, does mean that your periods will stop. But as long as your ovaries are left behind, you're going to still get normal ovarian function from those ovaries. And in terms of symptoms, you will go through a more natural progression of menopause around those average age ranges that I talked about. You will, however, not have a period. So that's a benefit of the hysterectomy, but that doesn't necessarily mean you're in menopause because your ovaries are still functioning. And people will ask me, well, how will I know? Well, if you're having symptoms, that's going to be one of our first signs, and we're going to talk about what those symptoms are. But we can also do labs to assess to whether or not you're in menopause for somebody that really wants to know. So now the symptoms. There's a lot of symptoms on this page. Some people will be very unfortunate and they'll have all of the symptoms and they'll be extremely debilitating and really impact that person's quality of life. Other people will have very few. They might be infrequent. And there's some really fortunate people that don't have any. And I think that's really important to understand. It's important to understand because one, oftentimes we're like comparing ourselves to other people, right? I do. You know, I'm asking friends what their experience is. I'm listening to patients talk. And if you're somebody that's having really awful hot flashes, and your friend looks at you and says, oh, stop being dramatic, that's not really helpful. Same thing if your doctor says that to you. So I think it is important to know that these symptoms will vary. For the most part, many times the symptoms are most intense, most severe around the initial few years around that last menstrual period. So that means even before your periods actually stop, we can start to have symptoms. And for like a couple of years after the menstrual cycle stop, we can still have some symptoms. For the most part, symptoms, especially like hot flashes and night sweats, last about 5 years after the final menstrual period. But in some patients or populations like myself and other Black women, we can have symptoms that last even longer for more than 10 years. So one of the first symptoms to be experienced, especially in perimenopause, is changes to your menstrual cycle. And they, just like I just said about everything else, they can be all over the place. Some people are really fortunate. Their periods just get shorter, they get lighter, they start to space out, and then they just gracefully go away. Other people, their periods might get heavier, they may get longer, closer together even before they go away. And then there's everything in between. There's even some people that they actually have a normal period, which today up until August 20th, and periods stop and then they just never come back. And so I think that being able to understand that things vary and what your experience may be different than someone else's, but it doesn't necessarily mean that there's something wrong. It just means that that's what your experience is like. Just like when we start to get menstrual cycles, some people get their periods at age 9, some people at age 12, some people at 16, and that's all within normal range. Some young ladies will get a period and then it'll be really irregular for the first couple years. And some people get their period at age 12 and it's like clockwork until it stops when they go into menopause. Mood swings, anxiety, depression. Mood swings can be varied too. Some people describe feeling extremely irritable, very impatient. Other people feel just sad, or things or that normally wouldn't get under their skin are getting under their skin. Somebody says something to them and they're immediately in tears, and they don't feel like they have really good control of their symptoms. These mood swings, anxiety, depression occur in about 40% of people, and they're more intense or more noticeable actually in that perimenopause transition. And it's thought to be related to the fluctuations in hormones. And once you actually go into menopause and you don't have estrogen or progesterone anymore, those symptoms actually get better. And people that have had a history of anxiety or depression issues in the past, even if you've been stable for many years, the incidence of recurrence is extremely high when we're entering into this menopause transition. Hot flashes and night sweats start to happen actually in the perimenopause transition. So, people will tell me, I asked other doctors about this. Like, I think that I'm starting to go into menopause. I'm having these terrible night sweats. They wake me up at night. It's disrupting my sleep. And because I'm still getting a period, the doctor told me that it can't be menopause. And that's actually not true. As I stated, with the hormonal fluctuations start to happen actually before your ovaries stop making the hormone. And so hot flashes and night sweats starting in that perimenopause transition are very normal. And as I stated previously, can start up to 7 years or so before you actually stop getting periods. So having symptoms in your late 30s or early 40s is actually pretty normal. Sleep disruptions, they can happen within the context of night sweats, especially if the night sweats are waking you up multiple times at night and you have a difficult time going back to sleep. But sleep disturbances also can happen outside of the menopause, or outside of having hot flashes and night sweats too. And we're going to talk a little bit about strategies for managing these things. Joint pains and arthritic kind of symptoms start to happen. We notice weight gain, and weight gain is another one that'll happen in that perimenopause transition. In fact, it can be pretty marked. Patients will say, Doc, I went to sleep and I feel like I woke up and I'm 20 to 30 pounds heavier. And I believe them, because it does feel like it comes on that fast. Much of the weight is deposited in the midsection here. I can't think of a worse place for it to go for vanity reasons, but also for health reasons too. When we put on more weight in our midsection, it increases our risk of other medical comorbidities like diabetes and high blood pressure. Even increased risk of cancer with having abdominal adiposity or that fat in the abdominal region. We are going to talk a lot about how do we offset that and how do we manage that. I think the first part is just knowing that it can happen and being prepared. Decreased muscle tone, we start to lose muscle going once our ovaries stop making the estrogen and progesterone, and much of that decreased muscle or loss of muscle is replaced by fatty tissue as well. So our weight-bearing exercises are going to be really important. Decreased estrogen also causes changes to our vaginal tissue as well as to bladder. So symptoms like vaginal dryness that can lead to pain with intercourse or even bleeding after intercourse. Certainly if something is painful, we don't want to engage. So decreased libido can be noticed. And even outside of vaginal pain, often decreased libido is a symptom that is extremely disturbing to women going through this menopause transition. And we'll talk a little bit about that as well. Thinning hair, changes to the skin, brain fog, feeling palpitations, or even feeling like your heart is racing. Oftentimes those palpitations can be associated with the hot flashes and the night sweats, but certainly they can also happen outside of that too, and can make you feel like you're having a heart attack or there's some cardiac thing going on. I think recently Oprah was being interviewed and talked about the palpitations and heart racing that she experienced going through this menopause transition as well. So now getting into treatment approach. And so the first thing I want to talk about is something that I, as a doctor, am not even giving you. These are going to be things that you need to be able to do for yourself, myself included too. We're going to talk about lifestyle interventions and really talking about some mind-body therapies. And then we'll move into prescription therapies. And sometimes people don't even need these prescription therapies if they are doing some of the other lifestyle modifications that we're going to discuss. So the first thing is it's so important what we are choosing to fuel our bodies with. I state this quote all the time to patients in the office when they ask me, well, what is the best diet? Is it keto? Is it Mediterranean diet? It doesn't even matter. I could go on and on, but I like to think about it not as a specific diet that you are following, but more so a way of life, or just being meticulous about what we're choosing to fuel our bodies with. We only get one. We're not going to get another one. We don't actually really get do-overs, although we can certainly change bad habits, and that can have a profound impact on our quality of life, even our life expectancy, even when we're making these healthy changes in our 40s and 50s, even if we hadn't done them earlier in life. But Michael Pollan says to eat real food, not too much, and mostly plants. And this simple phrase is absolutely true. Some people will talk about the 80% 20 rule. So 80% of the time I'm going to eat plant-based, and then 20% of the time I'm going to live or have the fun things. I'm not proposing that everybody has to be a vegetarian or vegan, but I am really encouraging people to really think about limiting the meat intake and really being intentional about how many fruits, vegetables that you're eating. A recent study came out and talked about people that are adhering to a plant-based diet can add 20% longer time to their life expectancy. And the same thing for exercise as well. And so, you know, I want you all to become a food snob, right? If it can live in a vending machine for up to 5 years and still be fresh, that's probably not something that we want to put in our bodies. If we're reading the ingredients and we can't pronounce the words or know where it came from, that's also something not to eat. I got laughed at. I was telling a patient yesterday that they had a party in the office, and there were cupcakes from, I guess it was Sam's Club, not to speak poorly of Sam's Club, but it was something like 50 cupcakes for $10.99. And I'm probably exaggerating, but it was a lot of cupcakes for a little bit of money, and everybody wants to make a profit. So if you could sell 50 cupcakes for $10.99, there's nothing in it that's good for me. So I'm not going to eat those, you know, but if there's some homemade banana bread that just came out of the oven, and I know that there's bananas, sugar, butter, vanilla, whatever we put in banana bread, I know those ingredients. Even though some of it, you know, might be a little unhealthy, it's sugar, I'm going to eat that. But it's really trying to maintain, you know, really eliminate the preservatives and the bad stuff, especially as we're moving into this next phase of life. Exercise is extremely important. People say, well, I always, you know, did 30 minutes 2 times a week with my trainer, and now that's not working. And so whatever we were able to do before, once we hit this midlife, we've got to do a little bit more. That's not good or bad, it just is. The American Heart Association recommends 150 minutes of moderate intensity exercise a week, and how you break that up doesn't much matter. You could do 30 minutes a day, 5 days a week. But the biggest bang for our effort at this time in life too is going to be making sure that not only are we getting cardio in, but that we also are doing muscle bearing exercise too. I love Pilates and yoga, I'm using my own body weight to do muscle toning activities. I have light weights that I'll use too with the Pilates. If you're someone that likes being in the gym, then, you know, lifting weights in the gym with a trainer works. Again, it's not about, it's really about, I should say better this way, of doing something that you like, that you enjoy, that you'll continue to do. Not thinking of it, again, as a short-term thing, but really incorporating regular activity into your daily life. So it could be parking at the back of the parking garage, and walking longer. It could be taking the stairs instead of the elevator. You know, instead of driving to the store to pick up the ingredient that you forgot, maybe walking to a neighborhood store. If the kids are rehearsing for their dance performance, or they're practicing baseball, instead of sitting in the car and waiting for them, doing some laps around the track while you're waiting for the kids. There's so many ways that we can incorporate some movement into our life. And just like those eating habits that I talked about that are so instrumental in enhancing our life expectancy and quality of life, regular exercises too. And there's, you know, what is the quote? You cannot eat yourself out of no exercise, and you can't exercise your way out of a bad diet. So they both work synergistically together. But studies have also shown that obese women are more likely to have frequent hot flashes that are more bothersome than those of normal weight. And even just a modest amount of weight loss is associated with a decrease in vasomotor symptoms. So in addition to the other healthy lifestyle things or benefits that you get with it, it can actually help with the symptoms that we're experiencing in this midlife transition. Sleep is important too. Sleep is extremely important in terms of weight loss. Lack of sleep is associated with increase in certain neurotransmitters, and those particular neurotransmitters control our appetite and feeling of fullness. And so when we aren't getting good quality sleep or sleeping long enough, we don't always have the ability to control our appetites, and we have a stronger craving for the high calorie foods or the high carb foods. Having poor sleep quality also results in decreased exercise. We don't feel like exercising if we're tired because we didn't sleep the night before. And also decreased sleep is associated with other medical comorbidities like metabolic disorders like diabetes and high blood pressure too. Two mind-body therapies in particular, cognitive behavioral therapy and clinical hypnosis, both have been shown to not only help with minimizing hot flashes and night sweats, but they can also help manage mood symptoms like anxiety and depression. And they've also been shown to help with improving sleep quality or helping with sleep problems. Both really are, I call it, especially with cognitive behavioral therapy, kind of talking myself off the ledge. I'll use the example of how it works for vasomotor symptoms. You know, if you're anything like me, I start to get the hot flash. I'm starting to get worked up, especially if if I'm at work about to do a presentation, or if it's in the middle of the night and it's woken me up. I'm fanning myself. I'm getting worked up. Oh no, now my hair is going to be wet. Only got 2 more hours to sleep, whatever the things are, but my anxiety is starting to rise. Oh, it's so unfair. Why is my menopause experience so terrible? And just in that simple state of working myself up, the hot flash is going to be more intense. My anxiety is more intense. The palpitations that I might be experiencing are more intense, versus being able to take a deep breath, right? I know what this is. I'm going to just have a drink of cold water, or I'm going to take a cold pack and put it on my neck or put it on my chest. I know that this is going to pass. Yes, my heart might be racing a little bit. I know this is a part of the hot flash. This is going to go away soon. And just some of that simple talking yourself again off the ledge actually helps. How it works for sleep problems. I wake up, okay, I know that it's not time for me to wake up, so I'm not going to look at my phone because that's going to frustrate me knowing what time it is. I know it's not the time for me to wake up because my alarm didn't go off, so I'm not going to look at the phone, but I'm going to lay there and try to go back to sleep. If I'm not able to go back to sleep, I'm going to have my strategies. Is meditation one? Am I going to get up and read something that's calming, fatigues my eyes, and then I'm going to get back in bed to go to sleep? So cognitive behavioral therapy is really just giving you coping mechanisms to manage the stressful symptoms. And what we find, even in randomized controlled trials, is that people that have these, that are adhering to these CBT techniques, start to experience less of the symptoms too. So it actually seems like calming our central nervous system down can actually help to minimize the symptoms. Clinical hypnosis is also taking you to a deeply relaxed state. And so the techniques also help improve the vasomotor symptoms, anxiety, and sleep problems. One of the nice things, if we can think about good things about the COVID pandemic, is that just like this virtual program is happening today, there are a lot of virtual options for even teaching yourself cognitive behavioral therapy at no cost. And so they're easy techniques that anybody can do. So now I'm going to move into medical therapy, right? We're going to talk about prescription options, non-prescription options, hormonal therapy options versus normal, non-hormonal therapy options, who should take what, who shouldn't take what works, what really doesn't work, how it works, and really, what are we treating? Because some treatments will treat one thing, but not another. Some may have good efficacy and may cover a few bases. But we want to make sure that we're treating the appropriate symptom with the appropriate medication. So 80% of people will experience hot flashes and night sweats. So we'll talk about that first because it's pretty prevalent. Again, everybody doesn't experience symptoms as severe as others. So for people that are having mild hot flashes or night sweats, they probably don't need treatment for that. But if you're experiencing moderate to severe hot flashes that are happening more frequently, that are disrupting your quality of life, then we want to talk about treatments. Non-hormonal options, there's certain antidepressants that have been shown to help minimize hot flashes and night sweats and may actually even help with sleep. Gabapentin is a neurologic medication that is used a lot with people that have neurologic issues or chronic pain syndromes, but it also has been shown to minimize hot flashes and night sweats. There can be some side effects, feeling fatigued or tired. And so oftentimes if somebody doesn't have any of those other neurologic or chronic pain issues, it might not be the best option because some of the side effects may outweigh the benefit of decreasing the hot flashes. Oxybutynin is another dual medication. It's actually used to manage overactive bladder or bladder symptoms. But it also can help improve hot flashes and night sweats. It can be associated though with dry mouth, constipation. So, you know, if somebody doesn't have the bladder symptoms, just using oxybutynin for hot flashes and night sweats, the side effects may not outweigh the benefits. But if you're also having bothersome urinary symptoms and bothersome hot flashes and night sweats, using oxybutynin and then maybe managing those other dry mouth and constipation issues other ways, it's probably maybe beneficial. Fezolinetant is a NK3 receptor antagonist. It was newly approved by the FDA back in May, so it's a new drug on the market right now. In the past, we had always blamed hot flashes and night sweats on decreased estrogen, not having any estrogen. And now we know that the decrease in estrogen actually triggers some other, we call them the candy neurons. There are other neurotransmitters in the brain. The increase in those are actually what throw off our body's ability to maintain our temperature status, I'll say. It kind of makes a malfunction of our internal thermostat. And if we can block those candy neurons, as they're called, from being released, we actually can reduce hot flashes and night sweats without giving someone hormone therapy. So that was pretty exciting. Some of the side effects, though, are headaches. Some patients in the study, there was a notice of increase in their liver enzymes. So people that are already having headaches or maybe have chronic migraine issues may not be a good candidate for this medication. And if there's any other medical conditions that are impacting liver and renal function, this may be a caution for this medication as well. When we talk about hormonal medications, we're talking about either estrogen therapy or estrogen and progesterone therapy. Estrogen therapy alone can be used for people that don't have a uterus, but if you still have your uterus, we need to be able to protect your uterine lining because estrogen can cause the lining to get thicker. And what we don't want to do is that to form either any precancerous cells or uterine cancer in the future. So if you still have a uterus, we give you progesterone to help thin the lining of the uterus. Our options are many if we're supplementing estrogen, and that's what we give when we're trying to minimize moderate to severe hot flashes and night sweats. It can be given as an oral pill that you take. That pill is taken daily. It can be a patch that you apply to your skin weekly. The patch can be, depending on which one your insurance covers, it's either a bi-weekly, so twice weekly dose, or once a week change. There are different emulsions that you can rub in your skin. Those are daily. And then there's a vaginal ring that gets placed in the vagina. It can stay in place for 3 months. After 3 months, you pull it out, throw it away, and you put another one in. For people, though, that have a uterus, as I said, we also need to give them progesterone. So there are combination pills that have both estrogen and progesterone in it together, that just taken once a day. There are combination patches that have both estrogen and progesterone in a single patch that you can use. Otherwise, we could use a dual option where we give you two separate medications. We give you, for example, the estrogen in a patch that you apply to the skin, and then we can either put in a progestin IUD, like a Mirena, to help protect the endometrial lining, or you could take progesterone pills separately. What hasn't been proven to work? Lots of herbal medications out there claiming to work. None of the herbal vitamin supplement things on the market actually have to prove prove that they work, right? They don't have to undergo FDA surveillance to get approval like prescription medications do. And I've read an article recently that said that menopause has become a $600 billion industry, and that on average, women are spending about $2,000 a year on menopause solutions, many of which have not been shown to have efficacy. And so all of the things that I've listed on the screen here, from black cohosh to evening primrose oil, maca, chasteberry, vitamin E, all of the things that are in many of the supplements that are being marketed or geared towards menopause treatments, in particular hot flashes and night sweats, when we look at them in randomized control trials, so we give half the people the herbal option and we give the other half of the people a sugar pill that looks like it, what happens is that initially those first couple of weeks, everybody at the same statistical significance say, hey, I think I feel better. But after a couple of weeks, it wears off or nobody feels better. And so there's this placebo effect that, especially when we think we're doing something good for ourselves, that we think, well, maybe because this is all subjective, right? Maybe I am noticing that I'm having a few or less hot flashes and I feel better. But then, like I said, again, most people, it starts to wear off. One of the other things too is sometimes things are coincidence, because our symptoms are going to fluctuate. And as I stated, the symptoms are most severe around the initial couple years after the last menstrual period. But for most people, the vasomotor symptoms get better as time goes on. So it may be that it just was coincidence that things started to get better too. If somebody's on something and they swear that it works, I'm not going to take you off as long as there's no contraindications to being on it. But I always have a hard time encouraging people to spend their hard-earned money on something that maybe hasn't been proven to work. So the genital urinary symptoms, as I shared before, the vaginal dryness, irritation, as some people will call it, the dryness can lead to pain with intercourse or sex. It can also lead to bleeding after any type of vaginal penetration. And we can also notice urinary symptoms like increased frequency, increased urgency. Recurrent urinary tract infections result from the decrease in estrogen and that impact on our vaginal tissues. If there are only mild symptoms, using just a vaginal moisturizer or a lubricant can be helpful. They're different. A vaginal moisturizer is like lotion for the vagina. And similar to if you put lotion on your skin, if you put lotion on today, it works really well. But if you don't put it on again for another week, it's not going to work as well. So the vaginal moisturizers are very similar. You need to use it at least 2 to 3 times a week to get the maximum benefit. And it's really just providing a moisture barrier to the vaginal tissues. And you're going to use that regardless of whether you're engaging in penetrative intercourse or not. Hyaluronic acid-based moisturizers have been found to function really well. And we want to make sure that you're not picking something that has any alcohol or preservatives or fragrance in it, because that can be very irritating. I do get asked a lot about, well, what about olive oil in the vagina or coconut oil? Or I've even been asked about vegetable oil. I am not a fan of putting, I'm going to put, say, cooking oils in the vagina. I know coconut oil has lots of medicinal purposes or people claim that it has lots of medicinal purposes, but I find that people putting coconut oil in the vagina increase their risk of having bacterial vaginosis or yeast infection. And over time, it has kind of a weird smell to it too, that not sure we want to be putting in the vagina. But like I said, hyaluronic acid-based moisturizers have been shown to be effective. Lubricants are something that you're going to want to use with sexual activity. So you're going to put the lubricant on either the vaginal tissue, on the penis, on a vibrator or a toy. And lubricants just help protect with friction associated with vaginal penetration. So both moisturizers and lubricants can be used together. And again, if people are experiencing mild symptoms, it actually works pretty well. If though a vaginal moisturizer or lubricant isn't working or giving you the maximum benefit that you would like, intercourse is still painful, then we want to look at prescription options. Low dose vaginal estrogen options are not systemically absorbed. They're only acting at the level of the vaginal tissue. There's a vaginal cream, there's a vaginal pill, a vaginal insert, and a low dose vaginal ring. This ring is different than the one that I talked about for managing hot flashes and night sweats because there's no systemic absorption. So it's not going to be enough estrogen to really help your hot flashes or night sweats. But in somebody that's not having bothersome hot flashes and night sweats, they're only having vaginal symptoms, the lower dose options are much safer. There is a steroid suppository that works rather well. And then there's an oral pill that's called a SERM, a selective estrogen receptor modulator. That SERM acts like estrogen on the vaginal tissues, but it's not actually estrogen. And all of these options work really well in terms of reversing those atrophy symptoms related to decreased estrogen. Sexual dysfunction and menopause, man, this is a big bag of worms. We're going to actually be doing a webinar specifically just to tackle this topic coming up next month. So we'll stay tuned for more of that. But if the vaginal or if the sexual dysfunction specifically is caused because it's pain with intercourse, that's an easy fix. The things that I just discussed are going to help, and they'll actually help rather quickly. I do tell people that using vaginal estrogen, you want to use it for at least 8 weeks before we notice the maximum benefit or symptoms are completely resolved, but it works really well. If though the issue is not it's not due to vaginal pain or dryness, but it's more of, I just can't get out of my head, or I have this block, I just don't have any more desire, then that's a different story. And probably just using vaginal estrogen or even systemic dose, the higher dose estrogen may not help, and we have to talk about other strategies. Testosterone comes up a lot. Testosterone we do not have any FDA approved options for testosterone for women. When we use it in women, we are using male approved cream at 1/10 of the dose. And most times we need to get it from a compounding pharmacy. And because we are using something off label, most times insurance doesn't cover it. Testosterone has been found, I will say there are randomized control trials that do show that it helps in postmenopausal women that have essentially decreased libido or desire. It is not like 100% fix where it works for everybody. And I always tell patients that if we try it and it doesn't improve, your libido or sex drive doesn't improve within 3 months, then we should stop it, because there are some side effects that could ensue from using it long-term, which the benefit does, or the risk does not outweigh the benefit if patients are not feeling relief from it. And some patients, especially if the vaginal pain has been going on for a while, so anytime we anticipate something being painful, we tense up, our bodies recoil. Our vaginal muscles are some of the strongest muscles that we have in our body. And so over time, what can happen is those vaginal muscles can create like a blockade. And then as soon as you try to engage in any type of intimacy that involves vaginal penetration, your body tenses up, and that tensing can cause pain too. And so many times pelvic floor physical therapy can really be instrumental in helping relearn how to relax the pelvic floor so that we're not getting those spasms or those pains. And so when I examine patients in the office, I'm always looking to see, does this person also have this hypertonic or really tight pelvic floor? Because I think that those people, in addition to managing or reversing the vaginal atrophy effect, they will benefit from having some pelvic floor physical therapy as well. The indication, so who should use hormone therapy and who should not? People that have moderate to severe vasomotor symptoms, moderate to severe genital urinary symptoms, so the vaginal dryness, the pain with intercourse, the urinary symptoms that we discussed. Someone that goes through premature menopause, and I have 45 on here, and it should be 40. So anybody that undergoes menopause earlier than the age of 40, as long as there are no strong contraindications, should be on hormone therapy until they would have reached the natural age of menopause, which, as I shared earlier, is about age 52. You notice that it does not say weight loss. It doesn't say hair loss. Doesn't say wrinkles or thinning skin. I don't even have the mood symptoms on here. So I think, hormone therapy lately has been touted as almost this magic pill or this antidote to aging. And I wish that it were. And absolutely, if somebody is having horrible hot flashes and night sweats, and I give them estrogen and progesterone, and it helps to minimize those hot flashes and night sweats, they're going to sleep better. If they're sleeping better, they're going to feel better. Their mood is probably going to get better. So it does, I agree, help with those things. But just to say, oh, I'm feeling not as energetic, I think I'm supposed to be on estrogen right now, that's actually not an indication and really not a proper use for the medication. The people who absolutely shouldn't be on hormone therapy or have their contraindications, I should say, and the risk probably outweigh the benefit. Anybody that has a history of a hormone-derived cancer, like a breast cancer, history of a blood clot or a pulmonary embolism, history of liver dysfunction or any cardiovascular disease like strokes or heart attacks. And that holds true for even bioidentical hormone therapy. Bioidentical just means that the molecular structure of the hormone is very similar to what our ovaries make, but it actually isn't what our ovaries make, so it still confers the same risk. It's been used as a marketing ploy lately. There are a lot of compounding pharmacies that are promoting bioidentical options like pellet therapy or injectables, and they make it sound like it's safer than prescription drugs, and it actually isn't. And in fact, it may confer an even higher risk because they don't have to have FDA approval and really don't know how much of the drug you're getting in your body. I've seen a lot of patients come in with very super physiologic levels after they've gotten pellet therapy, and that's what triggered a new onset blood clot in the lungs or the legs. So you want to be very cautious. The FDA, all of the major governing societies like American College of Obstetricians and Gynecologists, the Menopause Society, have come out with warning statements against pellet therapy and bioidenticals. The good news is, though, there are some FDA-approved bioidenticals for somebody that just wants a plant-based or something that has a molecular structure similar to theirs. So there are FDA-approved options for you. When is it best to start hormone therapy? The benefits outweigh the risk when we start hormone therapy closer to the onset of menopause. So if we started in somebody younger than the age of 60 and within 10 years of the onset of menopause, the benefits outweigh the risk. And people that don't have those contraindications that I talked about. Low dose local vaginal estrogen, though, that actually can be started at any time, and there's no time limit on how long you can use it. Because again, remember I said that those low dose local options are not as much systemically absorbed. With the systemic, though, therapy, once somebody, I'm not saying that as you magically you turn 60, we have to snatch it away. But we do really want to be cognizant and be mindful about reassessing risk every year. That's why we don't give you a 10-year prescription. We only give you a year's worth, and you have to come back on an annual basis to get it refilled, because I'm wanting to make sure that there's no risks that have happened in the last year, no new medical diagnosis, either in you or somebody in your family, that might make a difference. I also want to, make sure we're talking about these risks, because over the age of 60 or being on hormone therapy more than 10 years and actually is associated with an increased risk in breast cancer. It's associated with an increased risk of stroke and an increased risk of cognitive decline or associated risk of dementia. And younger people, those risks aren't as prevalent, but as we get older, it is. So I think really weighing the pros and cons of whether or not, one, when to start it, but also when to stop it is important. We talked about the mood symptoms earlier, so I'll just talk about treatment options really quickly. Being on a mood stabilizer, sometimes hormone therapy, especially if it's triggered to hot flashes and night sweats, can be helpful. Psychotherapy, we talked about cognitive behavioral therapy and mindfulness already. Lifestyle modifications, we talked about the benefit of exercise. Even just going for a 30-minute walk outside especially elevates our mood. It releases those happy endorphins that are mimicked in antidepressants, so the dopamine, all of the things, the serotonin. It's why people start posting their workouts on Facebook, because they feel excited about it. You feel better. And even when we feel like there's no way I could get up off this couch, I'll pass out, I'll throw up. We don't do that. And we usually within 5 minutes of the exercise or the walking, we're feeling better and may even sleep better that night. So pushing ourselves to get some exercise in can be extremely instrumental. Sleep problems, talked a little bit about that earlier. Hormone therapy especially can be helpful if night sweats are contributing factors. If night sweats are not a contributing factor, hormone therapy may or may not really be as helpful. Certain antidepressants, especially if we feel like we're sleeping because we can't get out of our head. Regular exercise, as I've talked about already, and then sleep hygiene. What is that? It means not sleeping with going to sleep with the television on or radio music in the background. That background noise actually is stimulating wake areas in our brain. So we're actually not getting a very deep sleep with those things going on in the background. When we wake up, not looking at a device, so not looking at a tablet or turning the television on or looking at your phone, because the lighting in those devices actually also stimulates wake areas and it makes it more difficult to fall back asleep. If you really can't fall back asleep, what most sleep therapists will say is to get up, sit up, turn on a light, and read something in print. And usually within 10 minutes or so of reading, it fatigues our eyes and you're able to go back to sleep. Keeping the bedroom that you sleep in cool too is also helpful, and not having a lot of just cotton sheets or, because if we're overheated, that also will not only trigger the night sweats, but also make the sleep quality is less. Hair loss in midlife and beyond as we get older can be pretty prevalent. There are lots of causes. Certain medications can do it, stress. Many of the hairstyling techniques that we use or products that we use can cause hair loss. But hormonal changes in menopause also can be associated, as well as genetic things. Diet and nutrition is helpful. There are some treatment options that can help. Dr. Victoria Barbosa, you'll see her on our website, is a dermatologist that specializes in especially in female pattern hair loss. And so if other things haven't helped, definitely seeing a dermatologist to see if there's any other things that are contributing or any medications that could help is the next step. I just mentioned Dr. Victoria Barbosa. She is just one of the many people that we've partnered with for the Center for Women's Integrated Health. This is the website. It's a little bit difficult to see here, but there are a number of specialized women's health programs. There's an a program that we have with the ortho department for a women's orthopedic program. We have a osteoporosis program, there's a sexual function program, sleep program, all of the lifestyle medicine, as well as primary care providers that have a special interest in midlife women's health. You're able to make a appointment through the website. You also are able to not only read about each of the specialized programs, and there's some Q&A answers that some of the important questions that patients have asked that we've put on there as well. But you're also able to read a little bit about the providers that specialize in each of those areas. And then I'm just going to end with a quote by actress Nia Long. She said, "We should talk about things for anti-aging, but not where it's like, I want to be young forever." You know, I think that we forget that menopause is inextricably tied to the aging process. And some of the things that we are experiencing is because we're getting older, and comparing our 55-year-old self to our 25-year-old self is really never going to be a winning comparison. So she says, let's remove anti-aging and talk about what you can put into your body to preserve your quality of life. And I hope that that's what I've stressed here today. I am more than welcome to answer some questions right now. And I know I went a little long, so if we stay over a little bit, I'm happy to do that if there are more questions. I will stop sharing.
Thank you so much, Dr. Christmas. Very exciting, something to look forward to.
It looks like it's I do see some questions here, and it says, I'm in year 11 of hot flashes. Does it mean I have them forever? And the vast majority of people, they do go away. But there are, and I call them chronic flashers. My mother happens to be one of them. So I feel like I may be one of them too, where the symptoms are not as severe or maybe as frequent as they were when you initially went through menopause, but they can continue to happen. And so we always want to make sure that there's not an underlying thyroid disorder, that there are not other medications that you're on. Certain antidepressants can actually, narcotic pain medicines are notorious for also contributing to hot flashes and night sweats. So I always want to look at other things. And if we come down to, it's still just postmenopause, it may mean that, you may be one of those people that has them for longer or always. After the presentation, can you please share some of the virtual options for cognitive behavioral therapy? Maybe, Brooke, that's something that we can, I don't have any links right now there. Many therapists, though, specialize in CBT, so that's one way to go about it. But if you just Google cognitive behavioral therapy, I think they're the American Psychology Association has some options too. Or if you do CBT and menopause or CBT and sleep, lots of stuff pops up. My OB-GYN stated that there is a small window that women can take advantage of hormone therapy. Why is that the case? So that was a slide that I talked about, that when should we start? It's best if hormone therapy is started if you are under the age of 60 and within 10 years of the onset of menopause. And the reason for that is because the incidence of associated side effect or associated things like breast cancer, stroke, cognitive decline actually go up when we use systemic hormone therapy, not that local low dose hormone therapy, but systemic hormone therapy. The associated risk increase when we've been using it for more than 10 years and over the age of 60. So that's why they talked about the window. And again, it used to be that we only would let people be on it for 5 years because it was thought, well, that's when the symptoms are the most severe, and then we would yank it away. And I think most people have gotten away from that, and we really look at each patient as an individual. What's pretty dangerous, though, is if somebody comes in and let's say they're 65 and they went through menopause at 45, right? They're beyond the initial 10 years of the onset of menopause, and they're over the age of 60. Starting somebody like that on hormone therapy actually increases their risk. And so that probably would not be a good thing for them. Are there any alternatives for those with history of blood clots and PEs? Yes. So those were all of those non-hormonal things I talked about. The certain antidepressants have been shown to help minimize hot flashes and night sweats. Gabapentin or Neurontin, as I talked about, has been shown. Oxybutynin, weight loss, we talked about, some of the cognitive behavioral therapy, the mindfulness or the hypnosis also has been shown to help. The new drug fezolinetant, when we, pharmaceutical companies are trying to get new drugs approved, they want to try to do it in an expedient fashion. So oftentimes you don't include people that have certain medical comorbidities. So I think it's really it's hard to say whether or not if that new drug is going to be safe for somebody with a history of blood clots. If I have a patient that has exhausted all of the non-hormonal things and they are miserable, if they are on full anticoagulation, I will work with their hematologist, of course, but use a transdermal option. So like that patch or the cream or the vaginal ring, because when we give hormone therapy as a transdermal, it doesn't have to get that first pass metabolism effect in the liver. And it's usually when things are metabolized in the liver that it bumps your clotting factors. And when we're using it as a patch, we don't have to go through that process. So theoretically, it should not increase your risk as much. I didn't say it doesn't increase it at all, but as much. And in somebody that is on full anticoagulation, the likelihood that they would have a repeat clot, even if they're on the transdermal, is pretty low. But again, that's pretty controversial. And that's only if the person is still really miserable, their hematologist agrees that it's okay, and they're on full anticoagulation. Estrogen is another over-the-counter kind of herbal supplement. There are some small trials that the company that makes estrogen has. There are not a lot of people in them, and they're not randomized control trials that showed some efficacy. When you look at randomized control trial evidence, though, it didn't have any benefit over placebo. So it's hard to recommend something that hasn't been shown to have more benefit. Why won't my gynecologist perform a hormone test? She states she can't tell if I'm in perimenopause by that test. And she's absolutely correct. Hormone levels are absolutely useless. I'll tell you, the only time it's helpful is if I have somebody that's 25 and has stopped having their period, or they're 35 and stopped having their period. And I want to try to differentiate whether or not this is premature menopause, is this polycystic ovarian disease, or something else. And somebody that is at the average age of menopause or perimenopause around that time frame, and they're already starting to have symptoms, checking a hormone level isn't going to tell me anything, especially if you're perimenopausal, because if your labs are in the normal range, it still doesn't mean you're not perimenopausal. It just means on that particular day, your ovaries decided to produce enough hormone for that day. That's why in perimenopause, our symptoms fluctuate. If the labs show me that they're in the menopausal range, I'm like, okay, but you're still having periods. So it still doesn't tell me that you're in menopause. And even when you're in menopause and we treat you with hormone therapy, we're not treating to some level, right? We're just treating your symptoms. And the levels also don't matter because, as I said, every symptoms are variable. There are people that are in menopause that don't have any symptoms at all. And there's others that do. There are people that are in menopause and don't have symptoms, but I've got people in perimenopause that have normal lab levels, but they're having terrible hot flashes and night sweats. So I'm not going to not treat you because your labs are normal. I'm going to manage the symptoms that you have. So that's my long way of saying I probably agree with your doctor too. I had 1 month of hot flashes that went away, and I don't want to have that feeling again. Am I going to have them again? Don't have enough information actually with that one particular question, because it's hard to say actually what triggered them. But I absolutely do have people that will tell me, you know, I had hot flashes for a couple of months, or I had them last year and they're gone and I never had them again. And so if you already are in menopause, then the likelihood that they're going to come back again is slim to none. If you are perimenopausal though, and you were having them and now you're not having them, once you go into menopause, there might be a chance that they come back again and we would have to manage. But certainly if you're menopausal now, you've gone that full year without getting a period and your hot flashes have stopped, then you're probably not going to get them again. Can a thyroid issue affect your menopause symptoms? So thyroid issues can actually cause symptoms that are similar to menopausal symptoms. So it's not necessarily that it's triggering menopause, but thyroid issues can certainly cause weight issues, right? Make it more difficult to lose weight. Hypothyroidism can result in thinning hair. Can also manifest in like dry skin symptoms, as well as menstrual changes too. So changes to your menstrual cycle. So that is something that we absolutely want to check, because thyroid disorders go up in the menopause. After a partial hysterectomy, can you still have cramping? Yes, partial hysterectomy usually just means that ovaries are left. And if your ovaries are still in place, that means that they're still producing hormone, and you're still going to ovulate until you absolutely go into menopause. And so you may still, especially if it's a cyclic kind of cramping, meaning once a month, you may still be feeling yourself ovulate. So yes, if your ovaries are still there, which is a good thing because you're still producing hormones. If we take your ovaries out at the time of a hysterectomy, you absolutely go into menopause. And surgical menopause oftentimes is associated with more severe symptoms, because one day you have hormones and a minute later, as soon as those ovaries come out, you don't have it anymore. How do I know if I can take bioidentical hormone therapy? So I would say that no one should take bioidentical hormone therapy that is coming from a compounding pharmacy. If though you are getting one of the FDA approved bioidentical hormone therapies, that's the same counseling that we talked to you about for non-bioidentical. Bioidentical just means that the molecular structure of that hormone is very similar to what your ovaries naturally make. So many people, when they ask me about bioidentical hormone, they're talking about injectables, they're talking about pellet therapy, and those things have not had to undergo strict scrutiny that other drugs that are approved by the FDA have to undergo. And so the risk certainly outweigh the benefit. And as I shared earlier, the FDA, the American College of Obstetricians and Gynecologists, Endocrine Society, the Menopause Society, I could keep going on the list, but they've made warning statements out against the use of bioidentical hormone therapy. And I know it's really popular now. It's really enticing. They make lots of claims. They're checking your salivary hormone levels. They're telling you it's safer, that it's going to make you skinny, that it's going to make your hair luxurious and long. But those claims have not been substantiated. And then how to increase libido and orgasmic function in a 63-year-old female. And so, man, that's probably more, that's going to be the next webinar. So stay tuned. Hopefully you'll be able to join us for that one. Not even just somebody that's 63, somebody that's even 23 that has orgasmic issues. Orgasms happen in our head, not in our genitals. And I know we don't think about it that way, but it does. And so our sex hormones are really the highest in our 20s. And they decline pretty rapidly starting in the 30s, and they then plateau out in the 60s. And so our libido changes over time. That's not to say that everybody is going to have sex drive issues, because oftentimes, as I said, things start out here, not just in the genital area. And so really answering the question about libido, orgasm issues, we are using kind of a multifocal approach of understanding what stresses that person is undergoing. Oftentimes when we're in this midlife transition, we are taking care of aging parents. Maybe our adult children have had to move back in the household. We've got more stresses maybe at work. Our partner may be having some erectile dysfunction too that impacts libido and sexual function. it, maybe that really it is related to some of our hormonal changes in menopause. And so the approach is really going to be, kind of a combination of things. Some people need sex therapy to help kind of think about sexuality differently, especially if they've had some traumas in their life before that are starting to manifest themselves. Sometimes it's couple sex therapy because there's some dynamics within the relationship because of other health issues that are impacting sexual function, and being able to talk about those things and ways of increasing or boosting intimacy that's different maybe than what you did in the past can be helpful. And then when everything else maybe has failed in the right person that hasn't had any other contraindications, using a testosterone cream may be helpful for those individuals. Again, it's off-label use and often not covered by insurance, so sometimes the cost can be prohibitive. I had my thyroid removed years ago, and on medication in place, do feel my symptoms have been more intense. My hot flashes, I feel, are pretty bad, especially in the morning. So I think what they're saying is that the thyroid medication seems to be impacting their vasomotor symptoms. So one, I would want to make sure that recent thyroid function testing has been done and that we actually have you in the right range, because sometimes just because you're on a thyroid medication doesn't mean we've corrected for the imbalance. If those symptoms are still prevalent, it might be that hormone therapy or one of the other prescription non-hormone therapy options needs to be added. Has there been a connection with women on Wegovy having limited hot flashes and night sweats? Not that I know of. I don't know of anything connecting Wegovy to either limiting them or making them worse. I eat fairly well, walk at least a mile every day, if not more, and occasionally wake during the night, but I don't have any night sweats, occasionally hot flashes, but I still find myself extremely fatigued throughout the day. Any suggestions? So kudos for the exercise. I think it sounds like you're eating really well too. I would, again, want to make sure that we've, tested for everything, make sure there's not any underlying other medical things going on, like thyroid disease. That's getting a big shout out. We keep picking on thyroid disease today, but again, it's one that's pretty common in prevalence in midlife. So making sure that that's not a fact too, that there's not some other autoimmune thing going on too. And then, kind of teasing things out and looking at other things. So it looks like that might be the last of the questions. Hopefully I answered all of them. Thank you all for joining. And if you need more, I guess, personalized attention, making an appointment with one of our menopause specialists.
Thank you so much, Dr. Christmas, and thank you all for joining us. I will send you guys a follow-up email with that information, and you all will receive a recording of this webinar once it's ready for distribution in case you want to go back and look at a couple of things. Oh, I was going to say, I think another question came in, but they said thank you. So yes,
Okay.
thank you again, Dr. Christmas. And one last thing, Dr. Christmas, can you let everyone know where you see patients, the sites that you see patients?
Oh yeah, I see patients in our Hyde Park location and also in Orland Park.
Perfect.
And I do have a virtual clinic every Wednesday afternoon. So, even if you wanted to make an appointment with that virtual clinic, and you could be at the comfort of your own home, or some people are in their car or at work. Okay.
Great. Thanks so much, Dr. Christmas. And I hope everyone else enjoys the rest of your weekend. Take care.